this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 4 conversations from Season 3, Episode 9, Louise Campbell's session asking whether we are making appropriate use of liver nurses and advanced nursing professionals in NASH patient management and education. In this conversation, the group shares some specific thoughts and concerns, ranging from whether a small portion of the money for systematic HCC medications can be allotted to earlier disease education, to use of Lancet competency documents and others like them to support training and program development. In the end of the conversation, each panelist identifies the change she would most like to see in the next 2 to 3 years. If we are to drive earlier treatment and education to minimize transplants, cancer, and deaths in the coming NASH pandemic, nurses have a critical role to play. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn and Facebook discussion groups.
Pam O'Donoghue.
I can say this because I work in oncology, but we've got so much systemic therapy for HCC now. Compared to 10 years ago, it feels like it's really got itself into the limelight, and that's great and everything, but we're spending billions of pounds on now something like 6 or 7 drugs that will prolong your life an extra few weeks or months. And I sometimes think, why is none of this money being invested way back at the start of the journey where Kate is and yourselves are going out and trying to prevent it from getting to that state? I mean, we've now got atezolizumab, lenvatinib, regorafenib, cabozantinib, clinical trials, SBRT, CERT. I mean, compared to 10 years ago, there was sorafenib. And I feel like all these CNSs are being hoovered up to manage all these patients going from TKI to TKI to TKI to TKI. And I think, but what about the start? It doesn't feel balanced. Is that a fair assumption of mine?
Michele Clayton.
Yes, I think it is fair, actually, Pam. But also, there's been a lot of interest in developing these different therapies, and obviously from a pharma perspective, some of those therapies allow their companies to profit. If we look at it in terms of our own populations, then if we think back to the UK in the 1990s, there was a big push about the government looking at renal and cancer and cardiovascular, and those are the services now that have reaped the benefits, whereas liver was not described even at that time. But actually it's been hiding underneath all of this, and then all of a sudden it's popped its head above the parapet and said, hello, look at me, I am the big problem now. We've somewhat been blindsided, and when I say we, I mean the population, the policy makers, everybody's been blindsided by actually all of a sudden we've got a massive problem in terms of people at risk and with liver disease, and unfortunately that is being replicated across the world. We used to see it in the US with their stats around obesity, but we're seeing that consistently now across countries that would never have had any issues with fatty liver previously now have those problems as well.
Louise Campbell.
And I think you're right, and what you described there and what Pam has described as a Western society that has access to expensive drugs, where it causes more problems, the lower socioeconomic countries and third world developing countries who will never get access to the expense of those medications. On one hand, we've got all of these great drugs, but we have no people there to locate disease early enough to stop them needing those drugs, and I think that's what Stephen was alluding to. If we can even target that for NAFLD and NASH quite early, my concern is if we don't have this expertise on the clinical front line, we can't have that discussion with people for early diagnosis. We can't have that discussion to get them into trials. And one of the reasons this podcast started was trials for fatty liver disease were falling by the wayside or failing to recruit. We have liver biopsies that require ballooning, and we've recently discussed how difficult it is in the tissue that we get to see one ballooning site and have histopathologists agree with it to get somebody included into clinical trials. So without a forefront of either nurses, primary care, it sounds from what everybody's describing as it's really difficult to have that conversation because we're not seeing people to be able to talk to them, to be able to get them into trials, to give them access to better treatments. It is a circular argument. Where do we finish it? And I suppose the last point is we've got obviously competency documents. If you're sitting somewhere else in the world and you want to access these competency documents that the Lancet Commission reported on, how can you take them and adapt them? Is there something you would suggest? Because I don't know whether you've taken them, Patrizia, and utilised them within your education work within the universities and that. I know you and Kathryn both work on the International Liver Foundation with EASL and that. So how are they being viewed as the only global competencies that we've got?
Just before anybody answers that, can I just say they are the most comprehensive competencies, but we do know that there are other smaller areas of work that has been done. So the Australian Hepatology Association have got some consensus guidelines that have been published between about 2019 and 2021, but more around very specific areas such as Hep B, Hep C, HCC, and also advanced liver disease. And also CARN, the Canadian Association of Hepatology Nurses, they do have again some specific competencies. Their most recent one, actually just published very recently, is around NAFLD as well. I suppose in response of the Royal College of Nursing competencies, they're there to be used. Anybody can go onto the RCN site and actually download a copy. Doesn't matter what country you are in the world. What it is then is about how do you adapt them for the nursing population within that specific country. What I would say is that I think there are core competencies that will cross-cut every country in the world. So things around pathophysiology, certain aspects of care, certain treatments, from an EASL perspective, and also the more AAH, CARN, ASLD, etc., we might be able to look at a common platform, and then it might be for each country, should they wish to, and if they could, then they could personalise that further to their country, because what we know is every country treats liver nursing differently. We know in Germany there aren't any liver nurses as such. So it's interesting to see how that might be able to be adapted going forwards. I mean, I don't know what Patrizia thinks from a Swiss perspective and your Swiss Hepatology Association.
Patrizia Kunzler.
Thank you, Michele. I'm not sure if the Swiss Association knows about the competency framework, as it is primarily a physician and scientific association. For us, it's very useful, the competencies, but what we see is that we have to speak in patient situations. What is a complex patient, what is an easy patient, and how we can use these special skills within the situation itself. And then it becomes more attractive how we can use it. So we take the story behind of a patient, taking care of this patient, and then the competencies are quite easy to use.
Stephen, do you know whether or not the American nurses, any of the girls that you work with or your nursing team, do you have a set of standards that's not in a clinical trial protocol, for example?
Stephen Harrison.
Yeah, I'm not aware of any. Again, getting back to what we were saying earlier, I think we need to all come to the same seat, same table, and kind of work through a unified message of what we want to say and how we want to deliver it, because I don't think that exists. Certainly my nurses don't have anything like that.
I know there's advanced NASH practitioners, and they're very well regulated and highly regarded, and I've met a few of those. But
well, certainly our nurse practitioners and our physician assistants, the APPs, advanced practice providers, have an additional skill set, but even there's no prescriptive message that we're delivering. More importantly, even at the LVN and registered nurse level, we should have some sort of prescriptive message that we deliver that's uniform across the board, whether I give it as liver doctor focused on fatty liver, or my colleague who's a gastroenterologist seeing patients in a general GI clinic, or a primary care provider, or an APP, or a RN, or an LVN, or a medical assistant. They all should be delivering the same message. And unfortunately, again, as we heard from our patient at the top of the hour, That just doesn't happen.
But also, I think it's important to set different levels within the competencies as well, because it's everybody's job, right? It's the clinic nurses. It's not just about nurse specialists. Okay, the ward nurses are quite busy, but even if they were to have a level 1 signage of the competencies, they're at least able to define to a patient what fatty liver is. Okay, they're not comparing and contrasting it with other diseases, or they're not critically analysing it, but at least there's a baseline level 1 knowledge. Then you get to decide as a unit, do you want your staff level 1 trained, level 2 or level 3 trained? And an example of that is when I was managing nurse specialists at the Harley Street Clinic, there was times when I didn't have cover for certain specialities. So I might have an esophagogastric CNS, but I didn't have a HPB CNS to cover a certain HPB clinic. So we would give the esophagogastric nurse the competencies and say, would you mind over the next 8 to 12 weeks to bring yourself up to level 1 at least? We don't expect you to know everything, but there's a certain amount of knowledge that we do want you to achieve in 12 weeks so that you can cover that clinic for 6 months. So I don't think we can expect that every nurse that comes across a patient is going to be an advanced nurse practitioner and know her stuff inside out. Even ensuring that there's a level 1 knowledge base that frontline nurses can achieve is important as well.
I think that's one of the things that we tried to do with the competence framework, was that it's at different levels. So you could even come in as a practice nurse in primary care and achieve something within the suite of the different competencies, and then we built them up so you had that foundation, and then you went on to specialist and advanced care. And that's one of the things that's important, is that in any competence framework that there's flexibility. People can see how it relates to them, and also it's at the right level for them. I think you make a good point in terms of we can't make everybody a clinical nurse specialist, but what we can do is furnish them with some fundamental skills that can be achieved whatever the country across the world, and whatever their role is as well.
Wonderful. And on that note, I'm going to start to draw you to a close, because we could discuss this topic forever. So I'm going to go around the table again, and I'm going to ask you to come up with one thing that you've heard tonight that's changed your practice, or given you something to think about as to how we can move forward with liver nursing to develop a better understanding. And what would you like to see happen in the next 2 to 3 years? Michele?
This has been raised before about having a sort of global liver nurse community, and there were certainly certain people involved, such as from the BLNA, so the British liver nurses, the Canadians, the Australians, and also the Americans. But I think it needs to be more substantially thought about, and also to be able to offer something that we know that NAFLD, we know that fatty liver obesity is this huge problem across every country now, that maybe we do need to do something more globally as nurses to try and offer a platform for nurses to be able to access, whether that be knowledge, skill acquisition, understanding, etc.
Fantastic. Kate?
Well, one thing that really struck me from what Stephen was just saying was about the importance of thinking about other clinical specialties that we could evolve to discuss patients with and situations. For example, the podiatrists. And that's a good point. What else do they need to know? One other thing that I'd be really interested in exploring in the UK would be to have a different type of formal liver course that's accredited. This has been talked about for years, and Michele is just creasing up with laughter here, because it is definitely something that's been talked about for a long period of time. But I'm just wondering whether something that's based on those core competencies in that document that would be a great starting point to then be able to formally say that someone's achieved at a certain level.
That's a whole programme on its own.
I know.
Yes, yeah. The major stumbling block is finance. Universities are very cash driven now, and that's become one of the issues with the change in the UK, certainly around funding of CPD, etc.
I've got a quick final plea really to anyone listening who might be involved in designing clinical trials, and that's about making a real effort with inclusivity and people's languages, because for example we have trouble recruiting to Hep B trials, on a slight tangent here, because people don't understand the patient information sheets because English isn't their first language, and there's no funding in the trial well to have an interpreter. So if anybody out there is listening and is involved in clinical trial development of any sort, it's, to get a more representative population. It just seems to be completely overlooked, and no one who's a senior clinician involved as part of this seems to be picking this up either, which is a real shame.
Is that with commercial companies?
Yeah.
That's interesting, because I'm surprised that's getting through ethics without provision for that, because certainly for HCC, we're able to get the commercial companies. To be honest, whenever we have open trials, they've never been readily available. But I must confess, I've always contacted the drug company, and I've had it delivered in 20 different languages for every trial. But that's me reaching out to the commercial company. And to be honest, they don't have to provide it. The trust probably should, the local R&D department probably should have sorted that out. But the drug companies have been really good about it. For example, with SUR, the internal radiation tape, they sent me it in at least 20 different languages when I asked Certex to do that.
Stephen will be able to comment on that one.
Yeah, unfortunately, in the fatty liver world, that's not happening. We can ask for a Spanish consent for our Hispanic population, but generally that takes 6 to 8 weeks after initiation of the trial to get it translated and then IRB approved. But to Kate's point, there's a lot of disparities in healthcare here, getting that out to people of Asian descent. I mean, Asians have just as much fatty liver as Caucasians do, and a lot of them live in the UK, a lot of them live in the United States, and we can't recruit those people. Vietnamese, Chinese, Koreans, you name it, we're challenged by that. That's a good point, Kate, and one that particularly with our phase 3 trials, we need to be ready to pivot with a wide variety of languages at the ready. Louise, with that, I'm going to have to go because I keep moving on, but it's so nice to meet you ladies and all the hard work that you do every day. And I hope that this podcast is really a nidus for change and an opportunity for us to be more collaborative as we conquer fatty liver disease and again, leave that big fat dent on the planet.
Fantastic. Thank you. See you later. Bye. Patrizia. All right, Pam, you go next.
No, I know, because it was just something I battled with so much with the languages. I must confess, I feel Kate's pain. But do you guys use language line? I mean, it's painful. I remember counselling patients through language line used to take me 2 hours.
And I think that's a particular British thing from that one. A lot of countries will use relatives.
It's a particularly British thing, but we have to give a code when we dial in. And if there isn't a code assigned to a study trial, then there isn't another one they can use. And it's just semantics, but it's really difficult. But it definitely excludes a population.
Patrizia, anything you're going to take away from this evening?
I take a lot with me, but I'm really aware also in this conversation all speak from collaboration, and nurses are important. But honestly, we are here, we are doing research, but we need funding, others have to see us, and we have to publish our results and disseminate. And I really look forward that we get a little bit more proactively invited and that our results also get implemented in clinical practice, because we are really important, and we try also on the European level to disseminate and to force nursing research. And especially in NAFLD or NASH, nursing care will be important, but if we will have trials on behavior change or something else, then it's quite hard to receive funding. So hopefully we can work also in this direction and can enhance the collaboration between all of us.
Fantastic. And Pam, what are you going to take away?
I'm probably not going to word this properly, but I feel like the British Liver Trusts need to be beating the doors down at the universities, making it compulsory that these nurses are coming out just below level 1 trained and ready for the outside world of fatty liver and the pandemic that we're in with that. I think they're a very powerful organisation, and you have huge parliamentary influence, and they could be a huge asset actually in all of this.
I'll feed that message back to the CEO there, Pam, who's also called Pam. So
yeah. We've been, because CERT was commissioned for HCC when NICE approved last March. There's only 10 centres in the UK, and there's meant to be up to 30. And we've just been struggling to get them commissioned because NHS England is on its knees. And we've contacted Pam, and I've just been really shocked and impressed with the support they've given us, and the voice they have is huge, and we're making progress finally.
Excellent news. And I would like to thank you all for joining me and having this stimulating debate, because I'm going to take away from listening to you all is the fact that when we start to develop clinical trials for NAFLD and NASH, actually using the competencies of liver disease might give our research teams and the people who design those trials an understanding of what they're dealing with and a basic knowledge for the education. Michele, you said it. By utilising the education elements, you can put your own programs together and develop it out. As we design clinical pathways to look at international management of NAFLD and NASH, we actually are working from something that's fairly concentric and focused, and we can add pieces to that jigsaw puzzle that are specific to an African location. Or I talk a lot about Australia and Indigenous health and Indigenous populations that are extremely prone to fatty liver disease and liver cancers and things like that. So that's the one way I'm taking it about, and I've just got a picture in my mind of Pam doing her video podcast of that and everybody seeing it around the world. That is the strength of coming together, is that as we design pathways for fatty liver disease throughout the world, we can design it with nurses key in every element and every area to help support our medical colleagues deliver better care, better outcomes, and get these drugs in.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We will be back next week to look at different estimates of the size and structure of the NAFLD and NASH populations in the US, UK, and Germany, and to ask what we can infer from these different estimates about the scope of the disease today. Until then, keep your distance, stay safe, enjoy the weather, whatever it is, as best you can, and we look forward to seeing you soon on Surfing the NASH Tsunami. Stay safe, surf on. Bye-bye now.